The ERAS program has been a great success, and the aim really is to ensure that the patients have a much better experience and their recovery is good and quick. The clinicians always strive for good quality care and taking management along is extremely important because they need to put in the relevant infrastructure and the attitude and the organizational aims to enable this to go forward.
Traditionally, finance has been seen as a bit of a threat, trying to stop anything, trying to stop all innovation. We need to be perceived now as a kind of a partner, working in collaboration with the clinicians.
There has been at times, and in some areas, a perception that the clinicians and management are on the separate side of the fence, which I think is unfortunate and wrong, because you cannot deliver high quality care with the two being opposite ends of the spectrum. And I think both sides need to understand that our aim is the same.
If you want to change the pathway of a patient, you have to be able to prove that you are not just having clinical outcomes are better, but also the financial outcomes as well. The finance should be seen not as a threat, but as a partner, or with the clinician should be like a business arrangement.
Well, it was about a month, 5 weeks ago, we were invited to come here, and that was very, very helpful. You know, they showed you how you'd walk upstairs and that sort of thing, and you know, all the questions I wanted to answer. You know, what do I bring in? What do I wear? You know, and they were very, you know, very careful to explain everything to me. You know,
what we found in the pre-ERAS days was that the patients were staying over primarily because they had a lot of nausea and vomiting for the first 2 or 3 days. So now what we've done is we've gone away from morphine and opiates more or less completely. So they are able to mobilize almost immediately within an hour or two of the surgery. And that brings them a lot of confidence, and that reduces the hospital stay by a good 50% or more. So our length of stay, for example, has gone down from 7.5 days to 3 to 3.5 days.
I've had total knee replacement on my left knee. The surgery around about 9 or 9:30 in the morning. I was back on the ward before midday. I was visited by the pain nurse around about 2 in the afternoon. The physiotherapist came at 2:15, and having checked that I wasn't in any pain or discomfort or having any problems recovering from the anaesthetic, I was on my feet at 2:15, and I walked I think around about 10-15 metres from the bed to the bathroom and back. So I think the majority of people that are in hospital are just, so long as they're not dreadfully ill, are waiting to get home, and I think it's comforting to get home and get in your familiar surroundings.
I think quality and cost benefit go hand in hand. So if we are providing high quality care, first of all we have less complications, so we are saving money there. High quality care means the patients are more satisfied, so we're saving any potential litigation and complaints. High quality care means that the patients recover quickly and go home quickly, so we can do more of the work, and therefore we are again saving money. But high quality does not cost more money.
It's a win-win-win situation for everybody. For example, with the ERAS, you're going from about 7 days down to about 3 or 4 days. So potentially with an ABMU health board, we see about 2,200 hips and knees. So potentially you're saving maybe about 7 to 7,500 bed days, which in effect would actually save you 20 beds.
We are in a position now to nearly double our throughput with no extra resources at all. I mean, I'm absolutely clear that high quality care does not require excess money or extra money.
I think ERAS is very successful. It's great for the patient because instead of being in for 7 days, you're in only for 3 days. We'll want to be in hospital the few times as possible. You have the great quality of care. Clinically, it's very good. And there's also the side benefit of financial savings. And if I'm being honest, what I kind of don't understand is why we haven't done it previously. It just sounds, you know, it's so good. It's just the question is, why haven't we done it previously? Why don't we just get it rolled out as much as possible?